Hello, everyone. This is Chris Frederick with the Collaborative Care Collective, and I'm very excited to be here with Gail Wetzler, DPT. And the initiative that we're talking about is our second seminar on June 27th to 29th, 2025 in Denver, Colorado. And specifically, we're going to talk about why this Collaborative Care Collective, or as we like to fondly call it, C3, why it was formed and created and what we're going to do at the next summit. So without further ado, Gail, I'll let you take over and talk
Oh,
about the creation of the founding of the network and the collective and really what you do.
okay. Well, thanks, Chris. I really appreciate you taking the time to be with us and spread the word for next June. We are very, very excited to be able to present an actual second conference. When we gathered together in October of 2022, we were a round table of docs and PTs and say, what can we do to help possibly change the standard of care as we know it? Because those that were around the table were always interchanging ideas and working with different treatment strategies and calling each other and saying, what about this doc? Or they'd be saying, what about this, the PT who they might be talking to. So it was a dream of Tim Mazzola's, and those of us around the table really wanted to support him because when I first met him, I moved to Colorado. That's possibly why, because Tim and I both are in the Denver area that this conference is at least starting here because we have the ground foundational base. But when I moved to Colorado, I gave up a very, very big practice there in physical therapy, and I had 8 other therapists that work with me. But my kids moved to Colorado, and my kids got married and started having kids. So my husband and I really, really wanted to be out here. So I was starting all over. And Dawn Sandalicidi knew me because we took Diane Lee's course together in 2012 up in Vancouver. And so when she heard that I was moving from California to Colorado, she instantly said, "Please, can you be in my practice?" So I shared a suite with her, and so we just got along beautifully, and we shared patients. And she invited Tim to a lunch meeting, and that's where I met Tim. And what I was interested in the most was that he was interested in what we possibly had to say about patient care. And he gave us a case, we had a few answers for that. And so I was so interested that he had this heart as an orthopedic, no, a sports medicine
Mhm.
family physician to want to know perhaps what physical therapy thought of things. So that's how my meeting with Tim met. And then I saw Dawn's patients get a little bit better if there was some challenging patients that were not, particularly ligament laxity. And
Mm.
then came along more neurologically challenged patients that maybe we were not doing as efficient of a work on the clinical puzzle for this person. And we'd send on to Tim and his doctors in his office and saw changes.
Mm.
And then with our hands-on skills, you, Chris, have that same, our hands-on skills, finding restrictions, be it on the outside muscle fascial epimyosin level to as deep as the organ level, that may not resolve. We found, and in discussion with him, that perhaps hydrodissection might be a way to go. So I was finding, wow, what great collaboration that is happening here, not only amongst myself, but other PTs in the Denver area, body workers, Pilates that he would consult with. And we all kind of got to know each other. And
Mm.
from that, Tim said, I'd really, really like to share what we're doing here for the help of our patients. And we were on board from that point on. That's how it all started.
That's wonderful to hear because so often in my career as a physical therapist, I was frustrated by the lack of communication between what I thought was team members, or at least if you tried to reach out, you would never hear back from the physician or another physical therapist or another practitioner. It was more rare. It would happen occasionally. And I think that kind of communication is sorely needed because it's really about the patient.
Mhm.
We're all trying to help them, and we all don't have the answers by ourselves.
Mm.
And developing that network is so important. Really happy to hear about that. So this conference is specific on treatment strategies for the scapulothoracic and cervical shoulder pain and dysfunction.
Yes.
So what about that? What about that is so either elusive in standard of care treatment and how we propose to present something that is different than the standard of care?
Yeah. I think that those of us that are involved with it and last year saw how we came together. One of our bases is knowing anatomy. And in this case, we're really trying to understand dynamic anatomy. And so we can study dissection and we can study the books. But when we get into the 3D of the challenges of the quality of perception that we're going to be feeling with our hands, it takes some training. And through the training of being able to assess, read, or listen to the body into different levels of perhaps where the problem really is. The where and the what and how it's affecting the body is what we did in the first conference that was so exciting that we wanted to move it on to perhaps another very, very important area. And so the cranium and the neck and how interchanged they are with the anatomy of the dura, the neuromeningeal system, the TMJ, the upper cervical RCPM, those type of muscles and the interchange between neck and cranium is very intriguing. And yet sometimes we can't resolve perhaps without the depth of looking through an ultrasound.
Mhm.
So I'll give you an example that I went up to be with one of the docs, that's one of the major docs of our conference, Dr. Phil Steele. And I went up to Helena, Montana, and we worked on some patients together. And it was a concussion patient that this person has had 4 different injuries.
Mm.
And he has worked with the brachial plexus. He had worked with the posterior neck. He had worked with strengthening the multifidi. He worked with the shoulder girdle to give a base of support in the torso. But still, she was having dizziness, nausea, could not get through her workday, extreme fatigue. So
Mm.
he asked me to take a look at it, maybe from a different perspectives. And I went deep into the cranium, and the sphenoid at the tentorium was rotated in one direction. C1 was incongruent with that in another direction. And
Mm.
thus the rotation occurred C1, C2 that he could not resolve. And so these horizontal fibers of fascial restraint continued into the thoracic inlet, continued into the diaphragm. All were trying to compensate for each other and
Mm.
into the pelvic cavity. So was the primary at the cranial base? Yes, it was at C1, C2 where the RCPM meets the dura there. So that is where I started. But then I had to work with the hyoid, and then I had to work thoracic, and then diaphragm and breathing, and then to the pelvic floor to eventually her to stand up and sit up and be, wow, that's a bit different than I'm used to. And to see the follow through with that, because the bigger correction was really from a hands-on point of view. And we did a pre-evaluation with ultrasound and a post. And
Mm.
even Dr. Still was kind of jaw drop as to what we could possibly do to help, kind of strategize together if we're missing something. But the same thing happened with me with him because we saw a few patients together. And I have a patient that came in to see me, and I'm the 5th physical therapist this person is seeing.
Yeah.
And the others tried, and they tried, but it was a very severe motor vehicle accident. Headaches
Mm.
still prevail, a little nausea, but the brachial plexus injury and the numbness and tingling down the right arm still prevailed. And I found it through the brachial plexus, and I found C5 as the primary dysfunction. And it kept, as much as I would help, have a little bit better range when he left, he'd go and work on his computer, which we stopped for a while, or do activities of daily living, and that inflammation would come back.
Mm.
And so I was missing something. I wasn't finding something that perhaps was all inclusive. So I asked this person to go up to see Phil. And sure enough, the ultrasound found an extension of the brachial plexus that not only was wrapped around the anterior scaling on this right side, but compressed between the anterior and middle. And I could not get to it without him going in and making the changes that he did, C5 through C8. And
Mhm.
then now this is about a month post. I saw this person right after, because he lives here in Colorado, went up to see Phil again to get a second set and a review. And sure enough, no more numbness, no more paresthesia. Found and worked with that eighth nerve, really. And then the 7 and 6 and 5 started to resolve their inflammation. And he is so no headaches anymore. Do I have a little bit? Yes. To work with the muscle compensation, the rest of the nerve and the dural tube compensation, shoulder strength to come back. That was for me to help him with. But the two of us together, we needed each other in that particular case. So I just wanted to give you a couple scenarios as to, wow, this is great strategy and collaboration together.
Yes, that was extremely inspiring for me to hear that about what we all, know as the complex patient. We would call it maybe amongst ourselves. And they are challenged. They've been to many practitioners. So it's wonderful that this person in particular, those two people, found resolution to their issues. So I understand that you also are director of the curriculum research at the Brawl Institute, and you're one of the instructors, the prime lead instructors. So do you bring that aspect to the summit on any level?
I do. One of the aspects, one is three aspects I'm going to bring. One is I'm going to be sharing with three different kinds of cases that Phil and I have worked together. So people see the before and after. I'm going to do an evaluation based on my hand skills and say what I think might be going on. He's going to follow up with an ultrasound to see what's going on. We're going to collaborate there. And I think it'll be super interesting for the audience.
Yeah,
He's going to do an ultrasound first. I'm not going to see it. I'm going to do manual therapy to find out where the restriction is. And we're going to collaborate together on what our findings were and the possibilities of how this is affecting the body.
I love it. You're both going to be in the hot seat.
Yeah, yes, it is. But it's an opener for those how important understanding the neuromeningeal system, the dura really has to do with the nervous system. And then in the lab, after that, both Phil and I are going to show the ultrasounds before and after on these patients. And I am going to show the people that attend that particular lab how to differentiate between a brachial plexus, a lumbar plexus, and a sacral plexus disorder. So that's one aspect. In the very beginning on day one, we're going to start out with Brad Fullerton. He's going to talk about it's complicated. And these patients that do come see us, especially when we share with people that we're integrative, they want to know a little bit more about the deep root cause of things. And so it's complicated, can develop into listening. And if we develop our skills in listening, both to the patient with our ears and listen to their story from the beginning into the possibility of when and how this started, it gives us a clue into it, as well as listening with our hands. So the Rural Institute is pretty phenomenal in knowing your anatomy and training the therapists that come through there in the quality of perception of their hands. And we do dissection labs over and over. We are combined with Gil Headley and our own dissection people. And the listening classes takes us through levels and levels of understanding when I'm on a periosteum or when I'm on a suspensory ligament for an organ or when I'm on a ligament that's perhaps intercostal and in dealing with the vertebral, like costo transverse ligament that we're finding some challenges in. So what are we on is the specificity of the work that we're going to talk about on day one, listening to the patient and how we bring that not only in from a dissection, I understand the anatomy is there, to dynamic anatomy, to actual when people are doing activities that they live in or their sport. So we want to listen at the time that they're coming. For instance, when a female comes into me and they're having challenges in their menses, and they don't at other times through their hormonal cycle, I want to listen to them when they're not in pain or inflammatory or endometrial tissue challenge. And I want to listen to them when they're in pain. And the body's going to give me a different perhaps reading as to
Mhm.
what I do at the time that they are in pain. So when a person comes in with shoulder dyskinesia, we're going to want to know what they are at a restful place, what their posture is like, how they're holding, what is dynamic as they move into shoulder range of motion, scapula patterns, breathing patterns, etc. We're going to be listening to maybe there's a restriction. And what we do is call that a visceral impairment. And that's where the Holberall Institute has taken musculoskeletal disorders and put it into a whole new world, is finding what is the depth of the problem as to why that shoulder dyskinesia is there. So on the day 3, I'm presenting a case that is strictly visceral impairment in regards to a pleural lung situation that started to freeze and cause an impingement on that shoulder. And they've worked with it. The docs have worked with it and worked with it. And it actually was deeper, and it required the training from the Burrell Institute to really work with that visceral impairment, to help the breathing pattern, to help what we needed to get a foundation in the thoracic cage. So the shoulder did have some foundation of strengthening. So then we can get the shoulder impingement in a much better place. So those are the 3 things that I'm going to be bringing forward in this next conference.
Very exciting to hear your full description in that anatomical detail and its moving or dynamic anatomy, not just the static cadaver, which we all learned it from, but it's more than that. So I would imagine some of our listeners are thinking that to learn how to listen and then how to implement some new skills, well, physical diagnosis. When I teach, it's always physical assessment or diagnosis. I find people that's where they're weakest. It's always and I'm always striving to get better at that myself. I don't know if we ever arrive. It's always that's why we're called practitioners. We keep practicing, right, to get
Yes,
better and
yes.
better at this. But these today, 2 things. People don't have time, or they don't make the time, I should say. If you're in private practice, maybe you can have more control over making more time, right? So the physicians doing more physical diagnosis instead of just the standard tests that everyone learned, let's say in orthopedics, it's much more than that. And I think you spoke to that both you as a physical therapist, but working with physicians, you're both actually doing more extensive physical diagnosis. And then, of course, the imaging to go with that. And the pairing of that is amazing because you're going to find things you wouldn't otherwise working together. So I guess without becoming too long-winded, so and physical therapists, what's disturbing a little bit is people in physical therapy are becoming less and less reliant on manual therapy. And that's a disturbing trend. And so you're inspiring me and others, hey, let's take another look at this. There is validity and reliability. And that may be opening up a whole nother conversation about, why physical therapists aren't doing as much manual therapy. But would you just say a few words there that ever comes to mind about physical therapists and physicians about using their hands more to explore both in the physical diagnosis as well as treatment?
I would love to. And what I'd like to give the example of is actually Jean-Pierre Barral himself. Jean-Pierre is 80 years old now. He was a physical therapist first, and then he became a DO because he found that he was disillusioned with electricity that they use, or ultrasound type treatments, or modalities, and some stretches that he taught years that was taught to him years ago. And he found there's more to the body. And so the philosophy of osteopathy is movement is a science. And if the gut body is moving and if there's flow to the body, then health of the terrain pursues after. So he became extremely efficient in understanding the manual skills to get to, I wonder what it is that's not allowing the movement on the outside. So he spent time in a lung hospital as a DO and understood that in the thoracic cage, there was lines of tension that he would feel from a hand in the posterior side of the body to the anterior side of the body. And he would not get a movement pattern, say in a certain ascending pattern, yet he would in another. And he wanted to know what was going on as to what was the depth of, if I'm not finding it in the ribs or the intercostals, is there something deeper in the body?
Mm,
Well, he's in a lung hospital where he spent time also with those that passed away.
mm,
He had the opportunity to see the postmortem of what he found inside a hospital bed to what was really inside.
mm,
And what he discovered was his hands were finding the truth. Even though an x-ray couldn't, an ultrasound couldn't, a CAT scan couldn't see exactly and what the direction of the line and how it was to possibly adhere to each other. He could feel the 3D approach of how restrictions affected the internal body to affect a lack of breathing or a lack of shoulder function or holding the head in a forward posture that no one else in that hospital could find.
mm,
So he perfected the diagnostics of manual therapy
mm,
into these listening techniques and into pre and post testing too. He did ultrasound. He studied, and it was 13 years in spinal mechanics at the University of Paris. And he studied and taught there, and what was causing T12 and L1 not to resolve with typical manual therapy of manipulation, both from chiropractic, osteopathic, whatever approach that was, how come it came back?
mhm,
So he would see what was on the anterior side of that or the lateral side of that, and the kidney may have been dropped, and that was causing the vertebrae not to be able to get back into its alignment. Or was there a structure that was anterior to even that? So we have support systems called mesentery and omentums that actually support the organs in its place. Well, did that become lax? Did it become too tight? Was it post-operative? Or was it post in maybe a gallbladder removal? So there's some scar tissue there. All those things counted for him as to
mm,
what was causing a vertebral restriction. And he started to believe his hands more.
mm, mhm,
So when you see him set up, this is your question is beautiful lead into this, because when you see him set up for the diagnostic of general listening, he puts a hand on the head and discovers where in the body. They could have a complaint up in the shoulder girdle like we're talking about, but it actually could come from another place from 2, 3, 4, 10 years ago of a history that eventually undid the compensation for a good foundation. So the shoulder can be a dysfunction because of the pelvic girdle and or because of maybe a uterus post delivery that a person has been having some problems with. And so that when we work with the uterus and the uterosacral ligament that supports the sacrum, and so the uterus was off after delivery, forceps delivery, suction delivery, uterus is off of its alignment. We help that. We help the ligament to the sacrum. Sacrum finds its foundation. Iliae find their foundation. Vertebrae find their foundation. Scapular pattern starts to resolve.
that's something.
So he is a man of, you can tell me what your problem is. We're going to listen now to the tissues. And so the where is the general, what is we find specifically in that region, what is the problem, how it affected the body. And then he sets up, Chris is amazing to watch, to get to the what, where, and how, and then to see what position he puts the person in
Mm,
to allow the body now to almost do a self-correction, because he's put the body in a position. We put our hands on and give the information from our hands that you've been challenged. What can we do to help you get back into your
mhm,
place? So there's direct and indirect techniques, but I want to emphasize that the manual therapy works with the continuation of the connective tissue and the communication changes. So any kind of dehydration or cellular challenges that has been there before, that starts to change because of manual therapy, and or the neuroreflexive response from the small nerves that affect the peripheral nerves, that affect the central nervous system, are in response to what we do as manual therapy. I cannot tell you how important the sense of touch is, not
mhm.
only from our receptors in our hands, but from the receiving of the information in our bodies. Touch is extremely important.
Well, you touched my heart.
Oh, thank
Just
you.
interviewing you this, and you've inspired me so much. And I think that's a good place to end the interview, although I can speak for a much longer period of time. But let's inspire others to take this summit, come to the summit, come listen to Gail Wetzler and other speakers that we mentioned at the Collaborative Care Collective, June 27th through 29th in Denver, Colorado, United States. We're going to be, again, discussing scapulothoracic. I'll just read the title. It's Multidisciplinary Conference on Treatment Strategies for Scapulothoracic and Cervical Shoulder Pain and Dysfunction. And we invite one and all to come, physicians, physical therapists, and allied health practitioners. Is there anything else you would like to add to that?
I would just like to say, for everybody that's listening, stay curious, stay excited like Chris just heard and what we talked about, the sense of touch. Stay curious. It just is such a wonderful way to be, because you know you want to help that person and the person reads that from you. So stay curious, everybody. Enjoy.
On that note, thank you so much, Gail.